Good afternoon, everyone, and thank you for joining us today for this particular workshop. We are here today from AIDS United to kick off the first of two sessions on building a stronger HIV workforce through racial equity. I am here with my colleague, Obrinka Thompson-Claiborne, and we'll introduce ourselves more thoroughly in just a moment. But first, to give a brief overview of our time together, we're going to spend about 10 minutes going through some introductions, logistics, objectives, and learning assignments or agreements, review some history related to race and racial discrimination in the public health sector, especially within the HIV movement, define key terms that would be useful in our understanding of racism and racial equity in HIV, do some interactive activities. I mean, who doesn't like to be interactive? That would allow us to start drawing some connections between these concepts and how they show up in our everyday work lives. And last but certainly not least, review best practices for racial equity and cultural humility as a primer for our next session. All in all, we will spend about 2 hours together. We'll have a 5 to 15 minute break for a breather, snack, bio break, and etc. So with that being said, let's dive on in. So who are we? Before we jump in, I would like to share a little bit about AIDS United. AIDS United mission is to end the HIV epidemic in the United States, and we do so through our grant-making portfolio of work, our policy and advocacy portfolio of work, and our capacity building portfolio of work. For nearly 30 years, AIDS United has identified, funded, advocated for, and provided CBA services to community-driven responses to the HIV/AIDS epidemic. AIDS United is headquartered in Washington, D.C., and has a Midwest office in Kansas City, Missouri. Today, we are here as part of our capacity building work funded by the CDC under the 19-1904 Cooperative Agreement. The AIDS United Capacity Building Team works in partnership with the CDC to provide no-cost technical assistance support to health departments' HIV prevention programs and their community partners in the Midwest region. As a part of this work, AIDS United specializes in social determinants of health, syringe services programs, harm reduction, condom distribution, data to care, and social marketing and social media strategies. And we'll pass it on and keep going.
Next slide. Yeah, one more slide.
All right, so I've been doing a lot of talking, but I haven't really introduced myself. So with that being said, I am Shambria Davis, and I pride myself on being a public health professional with a true passion for eliminating health disparities. I have completed my first degree in journalism, as well as my first master's in communication specialist, as well as my second master's in public health. So why not merge all the two together with the true passion and purpose that I have had. And I'm also a native of Valley, Alabama. And I'm going to now pass it over to my colleague to introduce herself.
Hello, everyone. My name is Obrinka Thompson-Claiborne. I'm also a native of Alabama, Decatur, Alabama, to be specific. I have been with AIDS United since 2020, so about 2 years, and I'm a program associate. I pride myself on being a public health and racial justice enthusiast and a budding medical sociologist. So I look forward to facilitating and talking with you all today. And so before we do that, before we really get into, the meat and potatoes, or, for our vegans out there, our cabbage and corn, we want to continue to drop some names, your pronouns, your organization, and your role in the chat. Some of you have already started doing this, so please feel free to continue. I did not mention my pronouns, but they are she, her, and hers. And so we look forward to seeing you all in the chat, your amazing organizations. And just feel free to pop those in real quickly if you haven't already done so, as some of you had. Thank you, thank you, thank you. And so this space is intended to be a conversational space. And so once we've worked through some of the logistics and level setting, we really do want to hear your thoughts, your reflections, and input on these topics. So please don't be afraid to use the chat box. There'll be different times throughout the presentation that we will ask you to drop some things into the chat. But if you don't have anything to drop in, there's always questions. So feel free to do that. And Chambry and I will make sure that we keep an eye open, and so that we can do our best to answer your questions. And if we can't, we will have some great follow-ups. And we also have reserved some time at the end for questions if we need to. Next slide, please. Okay, we're on this slide. Sorry about that. And so today's session objections are this. We hope that you explore. We hope that by the end of this, we would have done a great job of exploring the historical context of race and racial discrimination in the United States and how these dynamics impact HIV outcomes. We also want to make sure that you acquire a good grounded understanding of key terms such as structural racism, racial equity, and implicit bias. And we want to make sure that you discuss how they are operationalized via behaviors, cultural norms, and policies in our society. And lastly, we want to make sure that you learn best practices for integrating racial equity strategies into HIV prevention programs, as well as within larger institutions that you all work for. And next slide. And here we have our learning agreements.
So, Obrinka, you know, as you mentioned before, and I mentioned, like, this is going to be a very interactive space for everyone. And we want to uplift the following shared agreements. So first, use I statements. Let us know how you feel from your own personal perspective. It's okay to respectfully disagree. A lot of times we're not going to agree on the same things. That doesn't mean someone else's opinion is more valuable than the others. That means that it is okay for us to just disagree on certain things. And then pay attention to what moves you, such as oops and ouch and ooh-wee. So
Absolutely. And this might not be a safe space, but it will be a courageous space for all of us to learn and grow. And so make sure that any personal stories that we discuss as we have our questions, open discussion, that they maintain confidential within this Zoom room. Also, be disciplined about not making assumptions. Some things, like Chambria said, they might make you feel a little uncomfortable, but don't just jump to conclusions when you hear someone explaining or expressing a story. And most importantly, as we are working with multiple screens and cell phones and children and dogs and cats and everything, try to manage your technology to your best ability.
absolutely, Obrinka. And then, of course, take risks. Like with things in life, you want to make sure that you take risks. But at the same time, we also want to give you that safe space and respect to, you know, no pressure to speak at all.
And no blaming, no shaming. Like we said, we all have, fallen short and have had assumptions and implicit biases and said things that we might not want to have said, but no blaming, no shaming. Don't feel like just because you might have said something and you weren't educated on it means that you're the worst person in the world, because you're not, because you're here today and you're going with us. Next slide.
And then one last thing, Brink, I know we did a lot of talking about, you know, these different learning agreements, but I would also like to hear from others, whether you can drop it in the chat or you can unmute yourselves and say, what other learning agreements do you feel needs to be added? Because again, it's not just about me, it's not just about Obrinka, but we want to create a space for people to feel heard and voice their opinion. So if there's anything else that needs to be added, please feel free to unmute yourselves or just drop it in the chat momentarily.
Yes, I love that one, Jax. Don't yuck my yum. I like that.
Don't yuck my yum. I remember that one, Obrinka. Like anything in life, I feel is so important. When you have an opinion about something, again, it goes back to not always agreeing, but just because this person says something, that doesn't mean you have to yuck their yum. So I actually agree with that one. Yeah. And if they're not anymore, then we're going to proceed forward. All right, so what we can and cannot do today, as you see this graph that is on the screen, this particular graphic is one that we reference many times as we continue to discuss and collaborate on meaningful involvement in conversations around racial, social, and equity justice. However, in a nutshell, the main point that we want to make here is that this training is not an endpoint. This training today is not intended to, nor will it solve or absolve the HIV workforce of racism and racial discrimination. Rather, this is a piece of a puzzle, for some, a starting point. And I want to hone in on it's always good to start and to know that this conversation doesn't have an end point. It just goes to show that this conversation has the space to continue to make change and impact in community organizations. Our goal here is to give you the tools to move along this spectrum, to be able to create change in your communities and for your clients. This social barometer of change describes that as we learn about racism and other phobias in society, we move ourselves and we move people further away from being leading opponents and more so to be leading activists. Next slide. So with that, let's get started. What you'll see up here on the screen is an image depicting a growth model. And in life, if you decide that you want to stay the same, then you don't give yourself the room to grow. As we mentioned in our shared agreements, we want to push ourselves a little bit. The comfort zone is a place of limited action and change. So, Abrinka, when you think about those who are on this particular webinar, when you think about, the comfort zone, it's a space where, I'm good, I'm straight, I'm fine, I'm good where I'm at right now. And though that may be a good space to be at in the moment, when you rely so much on your comfort zone, you don't give room for yourself and your community and those who are leaning and dependent on you room to grow and have a better understanding. The comfort zone is a place of limited action and change, as you'll see here. The comfort zone is where action is limited, where excitement wanes, and really this is where we tune out. This is where we begin to believe that we have learned all that we have needed to learn, and we don't continue to challenge ourselves. We don't want to be here as we learn together, and especially with the particular topic that we're discussing today. Where we also don't want to be is the panic zone. This is where fear sets in, where we may start to freak out. And I know a lot of times, whether you have a presentation that's due or you have to present against the board, you're in a panic mode, and I understand that, but at the same time, that's not the particular place that you want to be in as well. We don't want you to be any of these spaces today. Between these two areas in the stretch zone, this is the place where we find the right amount of challenge and the right level of pressure. And I also agree with being stretched. You won't be able to be comfortable when you're stretched, but you may also feel a little bit of panic, but at the same time, it gives you that space and that nuance to know, okay, well, I know this information, I'm going to grow beyond my comfort zone, but I'm not going to overexert myself to a panic mode. We show this because we want to encourage everyone here today to stay in the stretch zone. We want you to challenge yourselves, ask thoughtful questions, and engage in some of these uncomfortable discussions, but we never want anyone in the panic zone. We will have a few reminders of this model throughout, but please keep in mind as we move through the session. Next slide.
All right, so let's kick this workshop off today by reviewing some history related to race and racial discrimination in the public health sector, especially within the HIV movement. And so I'll start by saying that for many, this won't be new information. For many as well, this can be very heavy and this is known through personal experiences. And so I invite you to step back as necessary, especially with everything that is going on in our world today. We have to remember to be gentle with ourselves and just be aware of what's happening. And sometimes you have to take a step back, listen to some music, or just have some quiet time. Make sure to take care of yourselves today. And so this information is important for understanding the roots of race and racism in the HIV field and how those have led to us today. But we recognize that hearing this information does not have the same importance for white providers as it does for people of color. And so once again, thinking about that growth model, as Shambria perfectly went over, think about the ways that it makes sense or it doesn't make sense for you to engage in the next 30 minutes or so. And as we move through this section, we absolutely will not be able to do a full history course on race and racial discrimination in the United States. As someone with African American Studies degree, there's so much that we could cover. So we'll just do some case studies and, to try to get our point across. Next slide, please. Okay. So we are going back as far as the end of the Civil War to really look at the roots of public health inequities following emancipation. And so there are countless examples that we can dig into that highlight the ways that racial discrimination has arisen in healthcare. And the one specifically here today, we will be talking about in Wilmington, North Carolina, as you can see on the screen. And so on the left-hand side of the screen, you can see James Walker Memorial Hospital. And following the Civil War, Wilmington became one of North Carolina's cultural centers for Black communities. In the decades following emancipation, the city saw an all-Black elected city council, a Black police chief, and the licensing of the state's first Black doctor, James Francis Schober, in 1878 to be specific. And so this progress did not last long, however, with white rioters and white supremacists running Black communities out of the city and taking over city government in just a matter of years. And so up until this point, hospitals were serving people of all races. Now, mind you, they were not doing so equitably, but they were still serving people of all races. But with the changes that came in place, the hospital was briefly open to all. And that's something I want to make sure to know. And so after the town was taken by white rioters, the James Walker Memorial Hospital, once again, which is on your screen, was open. And this hospital was large and well-resourced in comparison to some smaller, less resourced hospitals at the time. Yet they had all these resources. They installed racial bias and discrimination in the structures of healthcare within the hospital. And so the hospital has separate wards for men and women, and yet another ward for African Americans. And the ward for Black people was kept in the basement where there was little light, and disease tend to run rampant within this area of the hospital. And the hospital went as far as to use a color annex with the explicit implications that the care was not equal. And even Black physicians, ones who were licensed, were not allowed to practice in this area of the hospital. Next slide, please. And so examining the roots, here you see two different quotes that kind of show the differences within the experiences at this hospital. And so Black and brown communities in Wilmington were ejected to these harsh conditions. Examining the disparities in the ways that white soldiers and white families were cared for versus Black and brown ones was appalling. And it is appalling, and we still see these differences today. While doctors reported that white patients were spared no luxuries, anything that they asked for, they received. So meals of their choices, great care from the robust teams at the hospital was always guaranteed. However, Black patients were often turned away, misdiagnosed, or provided food that actually caused more illness on top of the illness that they were already experiencing. And so as you can see in one of the quotes on the slide, vermin were disgustingly numerous. The maggots were so thick in the soup that it was detected to be thrown away to prevent, the half-starved people who were actually at the hospital already from devouring it out of necessity because they were hungry. Next slide, please. And so as a result, separate hospitals were opened by and for Black communities. Where you can't find something that works for you, you will build it yourself. And so as pictured on this screen, community hospital provided quality and dignified care for people of color that could not be received at white dominated hospitals. Here, any licensed doctors were welcome to practice with funds and resources, as you may have guessed it, by the community. Yet the founding of this hospital and others like it were not the end of this story. Moving into the era of Jim Crow laws, Black hospitals were still understaffed and under-resourced. And most of these hospitals and clinics did not receive any form of federal funding, as it had to be privately funded as separate and independent entities. And so updated medical equipment, medication, staff, beds, foods, et cetera, any other things that we know that you have to update ever so often were very hard to come by when trying to provide adequate care at this hospital. And so key physicians like Dr. Daniel C. Roan, Dr. Leroy Upperman, and Dr. Hubert Eaton continued to challenge this system that hoarded quality resources and investments with white hospitals as the years went on, but kept them from Black hospitals. And so in 1956, these doctors sued James Walker Memorial that we previously discussed on the 2 slides ago, charging that hospitals that received federal funding could not deny staff privileges to Black people. Basically, you have to fund us, even though that we might only be serving Black people or that we might be serving everyone. And so I really want to emphasize that James Walker Memorial Hospital was opened in 1902. And so the conditions that we talked about on those slides and the experiences that were happening in the basement and with the separate wards happened for over 50 years with no change. And so the case, with support from Thurgood Marshall, reached the US Supreme Court and was eventually decided in favor of the African American challengers, or those who were staff and doctors at community hospital. Next slide, please. And so here on this slide, you can see over a decade later, a new integrated hospital opened, New Hanover Memorial Hospital, and it opened in 1967 while James Walker Memorial Hospital was closed. And so this hospital was notably open to anyone, regardless of race, creed, nationality, religion, or ability to pay. And it now includes 3 hospitals, over 855 beds, and is still serving this community and is one of the leading hospitals in this region. And so there's a lot of beauty and resilience in the system that exists here now. And with that, we have to recognize that extreme measures had to be taken to open a space in healthcare for people of color. And additionally, we have to recognize that this is not the end. In hospitals across the United States, inequity like this and during the Jim Crow era still exists. And those of us that work in these communities, as well as those of us that go to these communities for medical care, we see these differences and we have experienced these differences. And so we'll dig into some of the implications that exist today as a result of this history of white supremacy in healthcare. But first, let us emphasize that this by any means is not an exception to the rule. As we have seen here, this has happened in multiple places in history in the past and history in the current. And now we'll pass it over to Shambria.
So next slide, please. So a trend, not an exception. So Obrinka, you mentioned briefly about, diving into the roots. Okay, so you dived into the roots. So we're going to talk about a few trends in which race has played a key role in health outcomes and discrimination. So the first key trend is tuberculosis at the end of the Civil War. Similar to the case study we just reviewed, at the end of the Civil War, where there was a high incidence of tuberculosis in Black people, the medical and public health community said, well, that's because their bodies are inferior. Their bodies are inferior. Treatment for Black and brown people was often withheld under the assumption that their bodies or lives were lesser. Medical experimentation. We can also look into the history of medical experimentation on Black Americans from colonial times up until present day. There's a book by Harriet Washington called Medical Apartheid that really digs into this. But to summarize, she outlines the history of medical experiments on Black Americans, starting with enslaved people who have no legal protections on bodily autonomy, all the way into the 20th century, where certain procedures and their side effects were kept from test subjects who were people of color. From hospital abuse to radiation trials to experiments with incarcerated men in prison and the military, Black bodies have been largely abused and undervalued throughout history. Tuskegee. Of course, we have Tuskegee in the 1930s and 40s, in which informed consent was not collected. Keep in mind, informed consent is very important, and during those times, you had different experiments going on Black people without their consent at all. So how can you contribute to a study or contribute to equity when we're not really understanding what it is that's being done to us? So not collected, their status was not disclosed, and upon the development of treatment for syphilis, Black men were not offered treatment. 1918 flu pandemic. In 1918, when the flu epidemic hit the United States, it laid bare the racial inequities in healthcare. Black patients could not access care in predominantly white hospitals. In Washington, they either had to go to a Black hospital, such as Freedman Hospital, or the Public Health Service paid to have separate hospitals, say, in a school here in Washington. Last, but certainly not least, and especially what's going on now, we would be remiss not to mention the present day pandemic of COVID-19. The COVID-19 pandemic has brought social and racial injustice and inequity to the forefront of public health. For those who were not already aware of the disparities of privilege in and of itself, this pandemic showed us the ways that the structure and systems within our country impacted people of color. Everything from testing to treatment to vaccine allocations has skewed, negatively affecting the health and quality of life of people of color in this country. People really started to look at the ways that discrimination, insurance, transportation, occupation, education, income, housing, other social determinants of health were based in creating cycles of racism in this country. Now, I know that's a lot, but we cannot negate what history states. We share all this to emphasize how deeply embedded racism is in the ways that we work, the system that we operate in, the institutions that we support. Years and years and years of abuse cannot be unwound overnight. And we'll talk more about where we go from here in a bit. The next slide. But first, let's talk about the implications of histories, right? This graphic here shows the responses to 4 different phases related to medical racism and medical mistrust. They are: doctors treat African Americans and white people the same. In most hospitals, African Americans and white receive the same kind of care. Okay. You'd better be cautious when dealing with healthcare organizations. And patients have sometimes been deceived or misled by healthcare organizations. For the first 2, you see perceptions of medical racism. So in their mind, it's viewed as, okay, well, doctors treat African Americans and white people the same. But according to statistics, that's actually not the case. The same closely aligned with in most hospitals. African Americans and whites receive the same kind of care. We also see as well, this may be the perceptions of medical racism, but we also know that this is not the case as well. When we hone into medical mistrust, you better be cautious with dealing with healthcare organizations. Due to medical mistrust, African Americans feel, okay, well, you better be cautious because it has been those disparities that has been laid out. Patients have sometimes been deceived or misled by healthcare organization, and that is true as it is stated. As you can see, the perceptions and by the implications, experiences of medical racism among Black patients is significantly higher than that of white patients. As a result of these skewed experiences, medical mistrust is rightly higher amongst communities of colors. With hundreds of years of historical manipulation and deception on top of present day experiences of racism and racial discrimination, we find that communities of color report less trust and are less likely in pursuing medical care as a result of this medical mistrust and stigma. And that is why, again, we'll highlight over and over throughout this webinar, it is important to understand, though these topics may be kind of difficult to talk about, it needs to be addressed so voices can be heard and problems can be rectified. Next slide. So keep in mind, as we start to pivot our conversation towards race and racial discrimination in the HIV epidemic, we're going to start off with a quick 3-minute video. And if anybody is like me, I love a video in a webinar. It might seem a little straightforward, but we want to start at a baseline and build there together. So with that being said, we're going to watch, and yeah, we know, just give a disclaimer. The person in this video, her name is Karen, but that's the video, that's not us. So we can start the video. And as the video is gearing up to start, if you all have any feedback or any questions or anything, please feel free to put them in the chat. Again, this is open conversation and dialogue, and we want all opinions and voices to be heard at your discretion.
It's different.
It's the same.
Karen, you're not listening.
I am listening. You're just wrong. We're all the same. HIV is HIV.
Hey, what's up, you two?
We're doing a report on HIV, Karen thinks it affects everyone the same. I am trying to tell her it doesn't.
It's the same for everyone. If you get HIV, it attacks your immune system, no matter who you are.
Well, you're both right. It doesn't affect the body differently. But there are differences in how it affects communities. I'm actually taking a course in health disparities, and we were just talking about this today. Health
what?
Health disparities. Here, let me share Michael's screen so I can show you a few things. A health disparity is when a disease affects some groups of people more seriously than others.
Wait, I thought HIV wasn't that serious anymore.
It's still serious. We just have more treatments that can help people living with HIV stay healthy throughout their lives. But it wasn't always that way. At the height of the epidemic in the 1980s, some people thought only gay men, transgender women, and people from Haiti got HIV. This led to a lot of bias and fear towards these groups of people. Most of the people in charge of things in government and at big corporations weren't members of these groups. So, for them, finding a cure or a treatment wasn't a high priority. That meant people with HIV were dying pretty quickly after being diagnosed. This is an example of a health disparity that was caused by homophobia, transphobia, and racism. In fact, it wasn't until a white teenager named Ryan White got HIV through a blood transfusion that the government started funding HIV prevention and treatment. Weren't the first HIV medications really expensive? Yep, only rich people could get them. Others had to find cheaper medications illegally or were left untreated. That's an example of a health disparity caused by classism. Classism is the incorrect belief that wealthy people deserve something, in this case healthcare, more than anyone else.
But aren't things better now?
For some people living with HIV? Yes, a lot is different today. There are more HIV medications, and they are more affordable.
But racism and homophobia still exist, right?
Yep, so people of color may not feel safe going to a healthcare provider if they've experienced racism at a clinic before, or just because of the racism they experience on a daily basis. Same for gay and trans folks, right? Right. And HIV medications are still expensive. If someone's unemployed or is homeless, it's still going to be hard to get treatment. HIV may affect everyone's immune system the same, but HIV and other diseases affect individuals, families, and whole communities differently based on people's income, race, immigration status, gender identity, sexual orientation, and more.
So HIV doesn't exactly affect everyone the same. Boy, I still have a lot of learning to do.
Well, before you do all that learning, can we finish our report on HIV that's due tomorrow? Looks like my work here is done. Whoa! I'm okay.
So as you all can see, it's just important to understand that there are differences when it comes to different communities, especially communities of color. As we saw in this video, mistrust and fear from the racist roots of the epidemic continue to impact communities that we work with today. Next slide, please. Thank you. Let's dive a little deeper, as we always do. Over the few decades, HIV and AIDS have continued to have a devastating impact on the African American community. Here you can see with the graph shown race and racial discrimination in the HIV epidemic. Of course, it is larger within the African American community. In 2014, for instance, African Americans comprised only 13% of the United States population, but accounted for half of all new HIV and AIDS diagnoses. Black adults and adolescents are now 10 times more likely to have AIDS than white adults and adolescents. Subsets of the Black communities, especially young women and gay, bisexual, or same gender loving men, experience even higher risk. Today, Black communities continue to be diagnosed with and die from HIV and AIDS far more than any other racial or ethnic group. Next slide as I pass it over to Abrika.
And while we're waiting for the next slide, I did want to bring something up that was in the chat. Henrietta Lacks. We truly owe literally everything in medicine to Henrietta Lacks, who through the lack of informed consent did not know that her cells were being used to basically be the foundation of medicine as we know it today, as well as countless others that we don't even know their names to say. But the fact that we do know Henrietta Lacks' name, we will continue to say her name. And if you don't know who she is, I most definitely implore you to go do some research and to learn basically where penicillin, vaccines, OBGYN, maternal child and health, women's health, all types of anything in healthcare, like I said, the full gamut is owed to her. And so as we look at this next slide on race and racial discrimination in the HIV epidemic, as we've said, HIV's racial divide is not new. Each year when national surveillance data are released, we see the ever increasing toll that the epidemic is taking on the Black community. Each year we ask those same questions. Why is HIV hitting Black Americans hardest? While most of the existing literature focus on quality of care, healthcare access, or individual risk behaviors, we know that the HIV epidemic in Black and Brown communities results from a complex set of these social, individual, and environmental factors. Next slide, please. And so as we've mentioned those factors, that brings us to the social determinants of health. And so we'll quickly define the social determinants of health, and then we can look at specific social determinants that are related to race and racism. And so when we think about health, we have to seek to understand that sometimes complex intersections of factors that may impact our well-being. And so those intersections include things like, instead of focusing on changing individual behaviors through interventions and viewing health challenges as pathological, we have to really turn our attention to the dynamic intersection between the different layers of society that impact our social environment. So it's not necessarily individual behaviors, but it's that social structure that is causing or putting us in situations where we have to make decisions. And so looking at social determinants in this way allows us to explore how social determinants may impact our behavior individually. It emphasizes that there are systems of oppression and privilege that interact with structural factors, as I mentioned, such as healthcare, that when we identify this and we see these health norms within the community and perceptions of healthcare efficacy. And so it pushes us to identify new points of intervention. And so we're looking beyond individual behavior to look at system changes and to acknowledge that changes at any level of a system can impact other parts, or even the whole system. And so, for instance, when we look at unstable housing, when families need to spend too much of their income on rent and food, medical care, and other basic necessities, they might be, those basic necessities might be sacrificed, kind of like a hierarchy of needs. And so we see this with unstable housing, as we've all seen housing inflation, houses for rent, houses for sale, and even apartments for rent. And so family residential instability is associated with school failure for children, a lack of access to preventative health care, and the aggravation of a host of chronic health conditions ranging from cardiovascular disease to infectious diseases like HIV. And we know that from redlining and income disparities to zoning requirements, that the system that we have in place keep Black, Indigenous, people of color, or as I will continue to state, BIPOC communities from stable housing from HIV care services. And so next, we look at another important factor, which is high rates of incarceration of communities of color, especially for Black men. Incarceration is one of the most important drivers of HIV infection among the Black community. In addition to in-prison HIV risk behavior, such as unprotected sex and injection drug use, there are important questions about the role that formerly incarcerated persons play in transmitting HIV to others following their release from prison or in between periods of incarceration. And there are also major concerns about the level of HIV education, as well as testing, as well as treatment that they may receive while they are in prison. Next, we look at social norms and stigma. For instance, when we are talking about stigma, when we're talking about Black same gender loving men or men who have sex with men, they are less likely to identify as gay or disclose their sexual behavior to others. And so research suggests that homophobia and related stigmas that many men feel for both being at the intersection of being African American and a man who has sex with other men carries into their experiences with the healthcare system and can interfere with assessing HIV testing and other medical services. African Americans living with HIV are more likely than whites to have no medical care. And this is from African Americans who have 22% compared to 17% when we're looking at no medical coverage. And those who do have coverage are much less likely to be privately insured than whites, when we have 14% of African Americans with private insurance compared to 44% of white Americans with privately insured. And so all of these pieces across different social norms and human rights concerns, whether we're looking at unstable housing, incarceration, stigma, and healthcare coverage, create a context for which BIPOC communities are far more likely to face the impacts of the HIV epidemic and other epidemics than their white counterparts. And so we cannot continue to ignore these pieces when thinking about HIV prevention and care, as they impact the day-to-day and perspective experience that clients bring to us, and also that we will bring to clients as we are implementing prevention and care. Next slide, please. So what does all this mean? Why are we having this conversation? Why have we looked at this, this history, this context, and all this data? Because people of color are disproportionately suffering the brunt of the HIV epidemic in the United States. And HIV is not just a public health issue, but it is a racial justice issue. We cannot address HIV without addressing race and racism. I could say it all day. We cannot address HIV without addressing race and racism. Conditions of poverty and economic injustice, gender bias, gender-based violence, white supremacy, and racial trauma create settings in which the HIV epidemic continues to thrive. These are not natural conditions, but have been surgically precise, with precision, intentionally embedded into the structures of our society. HIV is not and never has been just a disease. This ongoing epidemic remains proof positive of injustice within our society. And ignoring these structural inequalities does not make them go away. Neither does putting on the emphasis of individual behaviors change by itself. And so by ignoring these issues, it's not going to make HIV go away. It's not going to make any of the other chronic and infectious diseases that we are experiencing on a daily in Black and Brown communities go away. And also by putting the emphasis on individuals to make those change, oh, well, you just need to do this different, or you just need to do this different, will not make a change unless we make changes to the structures in which we live. And so in this work and in our engagement with providers, we hear phrases like, well, I treat everyone the same, or I value all my clients equally. And with deep appreciation for your work, I don't want to take away from anyone the amount of years, the expertise that you bring to the table. I don't want to take any of that away. But we have to understand that the care and the lenses of equality are not enough to fix racism, because everyone has been uniquely made and they are unique in their experiences, and we have to treat them uniquely when we see them. So it's not, it's to each their own. It's not to each the same. It's equity. It's not equality. And so with the legacy of medical abuse in the United States, we have to be intentional about not just avoiding being racist, but actively engaging in anti-racist practices and putting racial equity into the work that we do. And that's what we're going to start digging into as a collective. Hope you all are ready as I pass it back over to Shambrita.
Thank you, Obrinka. On to the next slide. All right, so defining key terms. Now, we've talked about a lot and covered a lot, but I think it's important that we hone in on those particular key terms that surface and impacts the conversation that we're having today. With some context under our belt, we want to spend some time defining some key terms, grounding ourselves in common language such as racism, structural racism, implicit biases, and microaggressions, and concepts like the Gardner's Tale, will help us to build into some activities later. It will also give us the opportunity to make sure that we are all on the same page. Many of these terms are used and thrown around in daily conversations, and it can be super helpful to see that we're all basing our conversation and activities on the same information. That is so important, basing information, conversations, and having the same context on what we are talking about. As we go through, please feel free to respectfully drop questions for clarity and understanding in the chat. Next slide. So, first and foremost, let's define racism. But before we get into the context of racism, I want to give you all just a brief moment. What is your definition of racism? What does that look like? No right or wrong answers, just drop in the chat so we can get a feel of how this conversation will continue to flow.
And I do want to raise some comments that have been put in the chat. I am loving this conversation that Donald and Kiara are having, because Kiara is perfectly right. POC is a term that encompasses all marginalized or minoritized people. But when you are specifically talking about Black people, or you are talking about Latinx people, specifically say that community, because POC has been used as an erasure of Black and African Americans who have unique experiences that are different, especially not only for Black Americans, as well as Latinx Americans and people in our communities. Also, we do want to raise up and hold space for the continued violence that we're seeing in our communities, and how the people who were killed on yesterday in Texas were people of color, as well as in the supermarket a couple of days ago. And so we do not want to just overlook that. We know that the times we're living in are very, very hard. It seems that it's happening so much that it just becomes like second nature, but we will not continue to let this happen. As a community of Black and Brown and our white allies, we have to do this work. We have to continue to do this work. When we get tired, we have to see that we are tired and take space for ourselves and be able to recharge and come back, because this work is not going anywhere. As we've shown you from the historical context on race and racism, these things are slightly changing, but they are also staying the same. And so we have to continue to do this work and continue to be recharged to do these things. And so I'll pass it back over to Shambria. I just wanted to raise that up, as I do see your conversations in the chat, and I don't want you to think that we are not, we don't see what you're saying. So thank you.
Absolutely, Abrinka. Thank you so much. Again, referencing the whole growth model. Again, we have been, conditioned to be in this comfort zone, but also to having this conversation may gear people to think, oh, I need to panic. No, this is the area of being stretched. So some of these conversations and these references will not be comfortable, and that is okay, because in order for us to stretch, we have to be uncomfortable, but also be mindful not to panic. So as we go into racism, there are a lot of definitions that we can pull from racism, but as defined by the Centers of Disease Control and Prevention, racism is a system consisting of structures, policies, practices, and norms, all of that, all of that in the system that assigns the value and determines opportunity based on the way people look or the color of their skin. This results in conditions that unfairly advantage some and disadvantage others throughout society. What we want to emphasize in the definition on the screen is the systematic, institutional, and cultural pieces of racism. Racism is a lot of things, but it is so pervasive in the ways that it creates systematic discrimination through the institutional policies and practices of the society, and shapes the cultural beliefs and values of that society to support those racist policies and practices. So, in 4 simple statements, racism is race, prejudice, plus social and institutional power. Racism is a system of advantage based on race. Racism is also a system of oppression based on race. Racism equals a white supremacy system. Again, uncomfortable, beyond our comfort zone, but we're being stretched here. Racism is ingrained into our work in ways that we may have not always seen. Ultimately supports whiteness and condemns the values, experiences of Black individuals and people of color in communities. Now, at this time, before we dive into more, I'm going to pass it over to Obrinka, because I know we referenced a little bit of the Gardners Tale, and what better way than to have my colleague give us a better understanding through the Gardners Tale.
And so you can go ahead and go to the next slide. So when we start talking about the Gardner's Tale, we are looking at structural or institutional racism. And so with the Gardner's Tale, we have this discussion where we look at institutional racism, personally mediated racism, and of course, the last one leaves me, but internalized racism, excuse me. And so with institutional or structural racism, we have the gardener who has a preference for red roses. And so these red roses, when they're getting their garden together, they're getting all the things that you need to grow like the most beautiful roses. And so when you think about this in a community standpoint, you think of, oh, we're going to have grocery stores on every corner, easily accessible healthcare, street lights, sidewalks without cracks, all these things. But the gardener doesn't really have that much of a preference for pink roses. And so in their garden, they just get whatever soil that's available. And so we see that in communities that don't have access to healthcare, food deserts, the lack of equitable jobs and streetlights, and being able to have walkability in your community. And so as we leap from institutional racism and we go to personally mediated racism, this is where we see interactions of police brutality. This is where we see the interactions of mass shootings in our community. This is where we see interactions of not being able to receive inclusive care and be seen for who you are when you go into healthcare systems. And lastly, within the Gardner's Tale, after we have looked at institutional racism and we looked at personally mediated racism, we look at internalized racism. And this is when all those stereotypes and the marginalization that you have experienced in community gets embedded within who you are. And so as the gardener has shown that their preference is for red roses, now you believe that too is your preference, and you don't believe that you are special and that you are enough as a pink rose, or however you choose to identify yourself. And so as we look at structural racism, what Shambria was touching on at the end of racism and what we talked about as institutional racism is structural racism. And as we've mentioned, racism is all around us in everyday interactions and beliefs that we experience in community. But the normalization and the legitimation of these racial discriminations that we experience in community, and what makes them structural is how they have been put into policies and procedures that we experience here in the United States. And so white supremacy and racism is embedded in our culture through things like perfectionism, defensiveness, quantity over quality, hierarchical power, things just being black and white and no in between, power hoarding, as we have continued to see in our political climate, fear of open conflict, individualism, and more. And so I know that while we're having these conversations, some of you might see yourself in some of these things. And we're not here to say that each of these things is terrible or that holding or experiencing these is ultimately bad. What we hope to point out here is the way that racism isn't just hate crimes and name calling and explicit racial discriminations that we experience, but it is also embedded in the ways that our society functions, the way our healthcare system functions, the way our society puts, worth or emphasis on certain groups and not on others, as a lot of people from Black and Brown communities experience. And so we just want to keep that in mind as we continue to go over the next two definitions of implicit bias and microaggressions. And I will pass it back over to Shambria.
Next slide, please. Now we hear the term about, explicit biases and implicit biases. So for this particular definition, implicit bias refers to the attitude or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases, which encompass both favorable and unfavorable assessments, are activated involuntarily and without intentional control. We want to be clear that these biases are different from known biases, even if someone is concealing their biases for social or political correctness. These are known biases being controlled. Implicit biases or associations are formed over the course of our lifetimes. They are formed from a very early age through exposure to direct and indirect messages, media, news programming, environment, your family, your friends, etc. Over time, because of these influences, we form feelings and attitudes about other people based on characteristics like race, ethnicity, age, gender, and appearance. So I want to give like a brief example. This was given to me in one of my classes in graduate school. So just think about being in an elevator. So it could be, you know, a particular Black man, Black woman, whomever, and you may have a white woman. So she enters into this elevator and stuff, and all she is surrounded is around Black people. Well, sometimes in nature, an implicit bias may be clutching, you know, your purse a little bit. Or if you're in a neighborhood that you're not familiar with that has more people, you know, Black people than there are white people. So you may lock your doors, whatever the case may be. Those are implicit biases, although it's not being spoken, as though, you know, it may be something that you unconsciously do, but because of the environment and that you may not be comfortable about, that's where the implicit bias come in. So that's an example from my perspective. Everyone possesses them, and we really do mean everyone. No one excluded from implicit biases. Every person in this Zoom room, facilitators included, Obrinka and I, have implicit biases. These implicit associations we hold do not necessarily align with our declared beliefs or even reflect stances we would explicitly endorse, but they can influence our behaviors, our decision-making, and our thoughts. We generally tend to hold implicit biases that favor people who are similar to us, leading us to favor people who are similar to us in our choices and in our actions. This might sound intimidating or hopeless, but there is still a silver lining. There is still hope. Implicit biases are malleable. Implicit associations that we have formed can be unlearned, and new ones can be learned with intentionality, care, and commitment to impacting your understanding and views of the world. And especially in this webinar, we're having the conversation. We will actually do some of this work together during our next session. So keep these pieces in the back of your mind. Take it away, Obrinka.
Next slide, please. And so as Donald did so graciously well to have led us into our next point, we most definitely will be talking about microaggressions, and where implicit biases can show up without us knowing is in those microaggressions. And so when you do it on the elevator and someone pulls their purse close to you, that is the experience of microaggressions. As someone who has had this head of hair all my life, no, you cannot touch my hair. That is a microaggression. In interest of time, we would ask you to drop some examples of microaggressions in the chat. And as you do so, I will continue our discussion. And so even as we note, the piece of micro in the term microaggression does not reflect the impact of that comment. It's just the size. While the comment may be small, its impact is especially over time can be very, very large. And so consider it like a mosquito bite. 1 or 2 mosquito bites, especially in the South, you're doing real good. But if you were to get 1 or 2 mosquito bites every day for the rest of your life, that would be very, very frustrating. And so as we continue to talk about these terms and we get to our next activity, just continue to remember the things of implicit bias and microaggressions, race and structural racism as we continue this conversation as I pass it back over to Shimbria. Next slide.
So next, we're going to talk about power and privilege, the big no-nos, but it's also very important that we have this conversation. Again, power manifests and can be defined in a lot of ways, different ways of that. Just a few that we found to be key in this work includes the ability or official authority to decide what is best for others. Everything that's going on in the world today with the autonomy of women in their bodies and, you know, abortion and things of that plays into the ability and the official authority to decide what is best for others. The ability to decide who will have access to resources, the capacity to exercise control over others, and the ability to impose one's beliefs on others. hence, again, referencing power. Although power is often conceptualized as power over other individuals or groups, other variations are power with, used in the context of building collective strength, and power within, which references an individual's internal strength. Learning to see and understand relations of power is vital to organizing for progressive social change. As with implicit bias, power is something that everyone has. Everyone has power in some regard. Even being in this training, we as facilitators have a certain amount of power and influence, hopefully good influence, in the HIV workforce. Healthcare providers have a significant amount of power over their clients, patients, and communities. This is not something to be contested, but rather understood. Knowing our power, which we will explore more on interpersonal level during our next workshop, is vital in integrating strategies and tools for racial equity into our work. And again, I say power is not necessarily a bad thing. It's how you use it. It is how you project it on others. So again, just having this conversation about power and having the understanding that it's not all bad, but for this context, we have to dive in deeper. So next slide for Obrinka.
Next slide. Oh, this is the right one. Sorry. So as we've talked about power, privilege is closely tied to power, and those who have privilege are able to knowingly or not exercise power over those who do not. And so we define privilege, as you can see, as unearned social power according to the formal and informal institutions of society to all members of a dominant group. This access and advantages that people who are white, who are cisgender, who are English speakers, who are straight, and so on, have solely because of their social group, and one that people are typically born into or acquired through their environment/upbringing. And because of these internalized factors, individuals have unearned privilege. The reason that we emphasize the all here is that privilege can be granted as a result of one identity or experience that you hold, regardless of other experiences of marginalization. For instance, while a white queer person may experience marginalization and oppression because of their queerness, that individual still holds white privilege. And so everyone can exercise a certain amount of privilege. And as mentioned with power, everyone in this room has power and everyone in this room has privilege, but it's the way that you use it that can be good for humanity or it can be bad for humanity. And though it may be uncomfortable to recognize and to address power and privilege, that leads us, to oppression, marginalization, racism, homophobia, transphobia, et cetera. What we see in oppression is that certain groups, those who hold privilege and power in society, are able to define societal norms and the access that other groups have or do not have. And so someone, I think, raised this up in the chat, is that those who get to choose those societal norms have most often been old white men. And so we are trying to change that. And if we can't change that by getting new people elected into political offices, whether that is at the national stage or in the community, it's by also having the education to know that just because it's always been this way does not mean that it is okay. Next slide, please.
So up until this point, we've defined a lot of constructs and concepts that make up the world as we currently know it. Let's talk about a framework that moves us towards health equity. And for the sake of time, for those who are wanting to put in the chat, what's your own definition of racial equity? So as we do that, we'll dive into what it is. We have established up to this point that white supremacy structures access to healthcare, narratives about who is deserving of support and care, unjust policies and procedures. Racial equity acknowledges the structures and harms that our society has been built on, centering race, racial inequity, and racial justice in the solutions that we build. Racial equity is thus defined as a mindset and method for solving problems that have endured for generations, some intractable, harm people and communities of color most acutely, and ultimately affect people of all races. Strategies and tools that are rooted in racial equity look to dismantle the systems of oppression that harm Black and Brown people, that look to bolster the leadership of Black and Brown people in this work, and they look to make decisions that are informed by supportive and communities of color. We'll be diving into more of an activity a little bit later, and the other terms that we have explored are present in every day. But first, we want to share a quote that some of you may have heard before from Leela Watson. Next slide, please. So Leela Watson, who is a renowned visual artist, activist, and academic, says the following: "If you have come here to help me, you are wasting your time. But if you have come because of your liberation is bound up with mine, then let us work together." So again, we lift this up to note that centering race and looking at our work with a racial justice or racial equity lens is the path towards ending the HIV epidemic. Without thinking about how we dismantle these systems in big and small ways, we will not be able to meet the needs of our clients, communities, and ourselves. So being mindful with the work that we're doing, especially with ending the HIV epidemic, if you're honing in on one particular thing, whether it's me or one particular group, then the work that you're doing is limited. But when you join forces with other people and organizations with liberating these type of conversation and these type of nuances, then you do a greater work than just honing in on one particular thing or one particular issue. So we're going to pass it over to Obrinka as we go and introduce the panelists.
Thank you so much, Shambria. You can go to the next slide. We had a great activity set up for you, but this is such a robust and thick conversation that we're gonna lead over to our panelists. But before we do that, we have been talking for a very long time, and you all have been intently listening and interacting in the chat. So we would like to all take care of ourselves and take a brief 5-minute break. And so we will see you all back here at 2:15 Central, 3:15 Eastern.
All right, everyone, as we pass it over to Julio, I just wanted to reintroduce myself again. My name is Shambria, along with my colleague, Obrinka. We want to again just thank you so much for the time and the conversation. So with that being said, Julio, take it away.
Good afternoon, everybody. Thank you so much. And thank you, Obrinka and Shambria. Wow, that was phenomenal. An incredible presentation and a very vibrant discussion leading into this panel. And my hope is that we can carry that energy forward with our incredible trio of dynamic panelists who I've had the opportunity of working with before. Really quickly to everyone, if you don't know me, let me introduce myself. My name is Julio Fonseca, and I use he, him, el pronouns. I am Senior Program Manager at AIDS United. I'm working on the Partnering and Communicating Together initiative, which is our cooperative agreement with the CDC to distribute innovative messaging around HIV testing, HIV prevention, PrEP, and resources for people available in their communities at the hashtag Stop HIV Together. I also identify as a Latinx queer man who is currently in long-term recovery from alcohol use disorder. And I share all of those pieces because, we're not living sort of single lives. Those are all of my intersections, and that's how I show up when I show up into a space. And it's a good reminder for me as well to know that, everyone that I engage with in community is not just representing what I may think they're representing. There's a whole history and a whole life and a whole bunch of other things that make them a whole person. So our panelists do phenomenal work. I'm going to read off their bios really quickly before we get started with some questions. And I'll start, in alphabetical order by first name. Very excited to have Dr. Brittany Williams with us today. Dr. Williams she's worked with AIDS United before. She did a phenomenal Instagram live with us. She is an assistant professor of higher education and student affairs administration at the University of Vermont. And her research and professional advocacy focus on health disparities, epidemic injustice and citational erasure, classism, identity, and career development. She's been featured in and by the White House Initiative on HBCUs, the U.S. Department on Health and Human Services, NPR, the National Black Women's Health Imperative, One Day Studios, the National Minority AIDS Council, NMAC, and in a host of academic journals. We really enjoyed working with her on our Instagram Live about access to PrEP. Up next is, by alphabetical order of first name, is Kiara St. James. Kiara has been a community organizer and a public speaker. We've had the opportunity to work with her on our People Organizing Positively initiative. She's used her intersectional identities as a platform to highlight and bring tactile and systemic change to very diverse audiences, encouraging everyone to speak with their authentic voices and their truth to power. She was instrumental in changing shelter policies that were very discriminatory towards the trans community. She's presented workshops at International AIDS Conference in Vienna, Austria. She's also presented at the United Nations, and she was key in coordinating meetings with legislators to discuss the importance of passing GENDA, which is the Gender Expression Non-Discrimination Act, a bill that was legislated into law on January 28, 2019. She is currently the founder and current executive director of NITAG, the New York Transgender Advocacy Group. And last but certainly not least, Dr. Rafael Torruella, who has most recently been working with AIDS United as a part of our Hispanic Latinx People Organizing Positively initiative. It's a pilot program that's just wrapped up activity in February. I just wrote the final report. I just finished it this morning, 26 whole pages. We got a lot of rich data out of the evaluation process. Dr. Torruella earned his doctorate in social personality psychology at the Graduate Center of the City University of New York in 2010. After the completion of his dissertation titled Allá en Nueva York Todo es Mejor, which is here in New York, everything is better. A qualitative study on the relocation of drug users from Puerto Rico to the United States. While in New York, Dr. Tueja was a NIDA-funded behavioral health science training and postdoctoral fellow, an active member of the Graduate Center's Institutional Review Board. He currently, as I mentioned, is the executive director of Intercambios Puerto Rico, which is a community-based organization that offers harm reduction services and engages in pro-drug user advocacy in Eastern Puerto Rico. As a part of our HL-POP initiative, Intercambios has been working on meaningful involvement of people who use drugs in their staff and board leadership. So we have an array of talent here, and we have about 40 minutes to kind of go through some of these sort of bigger issues that really sort of, stem from the discussion earlier, but also talking about sort of real world implications and practicality. And so just kind of start off with a bigger kind of question, and then we'll kind of narrow into sort of specific pieces. But and this is to the panel. Feel free to jump in as you feel comfortable and see fit. But how have you seen racism negatively impact a person's experience with HIV prevention and treatment?
So I guess I'll go first. Can you hear me?
Yes.
Awesome. Yeah, I definitely know that racism plays a big part in how communities decide to get care. And I know, like, in my own personal journey of seeking medical care, racism played a big part, right? Where I remember one time I had an appointment at a clinic, and my appointment was at 11 o'clock in the morning. And the doctor came out, and I'm like, oh, that must be the doctor, right? So the doctor went to the desk, went back to his office. 12 o'clock came, doctor went to lunch, right? 2 o'clock came, 4 o'clock came. The maintenance person came out like around 5, because they were getting ready to wrap up for the day. And like, haven't you been here since this morning? The doctor hasn't seen you? I'm like, yeah, like, I've been in, my appointment was at 11 this morning. And so he's like, oh, let me go see if he's in. And the doctor had left, right? The doctor had left. And so I had to go to the receptionist. I'm like, why didn't the doctor see me? And she's like, I don't know why he didn't see. I told him you were right there. And so for many, many years, I did not go in for care, because, that type of experience of, not knowing if he did not want to deal with me because I am a woman of trans experience, or because I'm Black, or because of both. I didn't really care. But what I know happened was that it really sent me on this somewhat kind of negative outlook on medical professionals, and not trusting them, not wanting to go in for care. And so I know that it can play a big role in, like, when you go into a space, if you're not feeling affirmed, you can immediately sense that. And what can happen is, if the space is one where like very negative energy, and maybe not even by people saying anything or misgendering, or maybe just people ignoring you, it can really create a sense of like, oh, okay, so I must not matter here. And I think it took me like 2 to 3 years to get back into medical care, because I was just so traumatized behind, this doctor not wanting to see me and not even giving me a reason why. And I was so proud of myself that day, because I'm like, I'm finally being responsible. I'm taking care of my health, and I had that type of treatment. So I do know that it's very critical that frontline staff, as well as, the doctors, nurses, that they all get educated on, like, and understanding the community that they're going to be servicing, because it does such detrimental harm when folks go in and really want to be responsible with their health, and to be treated with such disregard. And it can take years to build that trust back up, right, of wanting to go back to any other medical facility to get any type of help. Because what's in your mind is how you were treated the last time you went in to get services. So it's very critical, that medical staff, even a maintenance person, right? Everyone is educated and understand the importance of making people feel affirmed when they're coming in to get services. Like, that's so critical.
Thank you for sharing that. That's a very obvious example of a bias that happened in a clinical setting. Dr. Britt, on our Instagram Live, I remember you covered some more of the sort of, and this was something that was referenced in the previous presentation, some of the more implicit bias, and I would love for you to share kind of your experience with that.
Yeah, absolutely. So I am a personal PrEP user on and off again since 2018. I have no idea what time it is because of COVID. So we'll go with 18. I think that's right. We can go back to the Instagram Live because I wrote it down that day. And when I went in to start my PrEP prescription, I outright had doctors who said they don't know what that is, who said to me, we don't do that here, who sort of talked about access to PrEP as something that is for a particular population, and that population isn't a young, heterosexual presenting, able-bodied Black woman like myself, right? Who's talking about dipping my toe into the dating pool because I'm newly single and I'm trying to figure out dating. And so I had to deal with a lot of questions, a lot of teaching medical practitioners what PrEP was, doing my own advocacy around my own healthcare. And I think that is one of the major reasons we have so many PrEP barriers today, and that PrEP barriers continue, right? So we know that for Black and brown folks, going into a medical setting is already anxiety inducing. You already know that folks are going to look at you a particular way. And if you don't have the advocacy skills that I have a PhD, I've been in school my whole life. I'm now a professor. I'm trained to teach people when someone tells you no, find the next person and the next person until someone says yes, right? No means no from that person and not no indefinitely. But if you're not socialized to have those skills, and we know that folks in communities of color, when we're dealing with health practitioners, we tend to think that is the final answer. We don't always go and get second opinions or ask for additional help. And so I had to deal with a whole lot of, are you sure you're doing that? I remember one of the people in the women's clinic saying to me, are you having that much sex? Which, first of all, girl, I wasn't, but if I was, so what? And what does that mean, right? Why can't I be having that much sex? And what does it mean for someone to have that much sex that they need a PrEP prescription? And so just those sort of negative attitudes that would be a deterrent to someone who isn't as vocal or comfortable saying, no, I'm taking my sexual agency, I'm wearing it on my sleeve, and you're going to give me what I came here for.
Absolutely. Rafi, I guess similar question, in terms of your research, I actually reading your bio, I was like, oh, I kind of want to read what he wrote about that. It sounds like there's a difference in care, right? From sort of one place to another. Can you talk about that a little bit?
Sure. And let's draw a little bit back, right? Racism, just like classism, these are systems, right? These are social systems. And we can talk about it as the individual and those individual interactions of racism that are very real, and that's where it happens. But it also happens in broader community, systems, right? And here in Puerto Rico, Intercambios Puerto Rico is a non-governmental organization that works primarily with people who use drugs, and within that group, people who inject drugs. So when we were setting up Intercambios, how did we encounter racism, and where did we see it, and what did we want to do about it, were things that we wanted to address, right? Because you want to, in a way, address this head on if you have a chance to build out an organization. And where do we see these differences? Well, HIV prevention in areas that were predominantly Black were not so present. And we would ask why. It's like, well, it doesn't work there, or they don't want it, or it's not working, right? It's like, let's go in a little bit into that and see really what's happening in there. Was it really done bottom up? I mean, was it done asking the community what he, she, wanted, right? Like where is the community opinion regarding where should we set up the systems? Where do you want your where is it more confidential to provide these services, right? So all that, and lo and behold, we went in and it started working very well, actually. And it's not because, oh, we're so great. It's just because I think we took care of looking at those racial dynamics. And many times the racial dynamics are proxies for class too. And this capitalist society, you know, and where money flows mostly through white folks, that it's a proxy for class. So race, class, gender, observing that, where do you set up systems to kind of, it's not like we're going to fix the world, but we surely want to take that into care to start balancing out at least our primary stuff, which at the time, and we've grown since then, doing HIV prevention. You know, where do syringes need to go? Because the HIV rates are high, because those communities with individuals in it have been, it doesn't work there, so let HIV be spread. And, you know, these are social determinants that are very real. So that's kind of how we started engaging it, and how we tried to level those services, because that help really needed to be there. So that's kind of like, of course.
No, that's fantastic. It sounds like you had an opportunity really to sort of build and put the meaningful involvement of community piece into that from the ground up. There are a lot of organizations, though, that exist and have existed for a long time. A lot of them are, we call the sort of mountaintop model, you know, the white tops, where the leadership is white at the top. It's like a mountain. And so what is the first step that an organization can take to begin dismantling racism in their systems?
I'll jump in and say processes and protocols. I love org theory. I love looking at organizations and systems and structures. And so for me, I think the first thing an organization can do is look at those things, right? We have way too many jobs, offices, organizations where it's last in, first out. Netflix is a really great contemporary example of what that looks like, where folks are saying we value equity, we value justice, but the only BIPOC folks on your team are people who are relegated to the margins of DEI work, people who are doing these sort of ancillary projects that aren't at the core and the mission of the organization. So when you reach financial turmoil, when a grant that you're waiting on from the government or another organization doesn't come through, when some of that soft money isn't available, they're the first people who go. And so that's a big piece when we start talking about processes. And then in terms of protocols, how are you engaging in your interview processes? Is it necessary to have folks come in and do an interview for an organization and you're giving them pop-up questions versus sending the questions in advance? Because if I send you the questions in advance, I know how thoughtful you are. I know how much time and attention you're paying to answering those questions in a meaningful way. And that's going to tell me a lot more than, are you good at answering something on your feed? Or can I stump you or stumble you in an interview? That tells me how good you are at recovery, but I can teach you that. I can't necessarily teach you empathy on a job when we're trying to get something done. I can't teach you how to engage these populations or how to care about them if you don't already do that. And so I think part of it is, you know, when we're working in these organizations and doing these job roles, how often is it that we have 2 minutes to come up with the answer to something? It doesn't happen that often. Even for me in my work, I used to be a residence hall director. That's where I started my career in higher education. So I would have students come to my apartment door in their residence hall saying, hey, this is the problem that I'm having. I don't know what to do. I'm looking at them, they're looking at me. You know what? I don't know the answer either, but here's what we're going to do. I'm going to walk across campus to this office. You can stay here in my home. I'll make you a cup of tea. I can come back with the answer, or you can walk with me and we can go over there together and find the answer together, right? And so I think part of it is also with organizations not prioritizing the answer having to be right immediately, not feeling like we have to sort of hire the perfect person immediately, because oftentimes those things are code for fit, and fit often means whiteness, it often means able-bodiedness, it often means heterosexual, it often means cisgender. And so there are all of these folks that we are leaving out in our processes and protocols because we make it hard for them to get into the organization in and of itself. And so that first step is, what are we doing in our interview processes? How are we hiring? How are we training? How are we retaining, right? There are some places that are a revolving door. They get all the talent of color and everybody somehow leaves. And so why is it that you can't keep anyone? And so I think some of that is going to be what is going to be required. It's that assessment and that look inward to say, this is what we're espousing to do. Here's where we are or we aren't living up to that.
Mm-hmm. Fantastic.
If I may,
sorry. Oh, I'm sorry. Go ahead, Kiara.
Yeah, and I think also, the word that we hear a lot, or I should say I hear a lot, is divestment, right? So how are we divesting from these white institutions, right? That primarily they create these fiefdoms for cis white men to like run this type of, like, I'm gonna be very blunt, like a plantation, right? Where on Black and brown folks, are kind of seen as the help, right? And that's one of the main reasons why I founded New York Transgender Advocacy Group, right? Because I worked in that environment for some 14 years with a very prominent, well-known organization in New York City. And, things we have to also understand is that oftentimes it's those organizations, the Black and Brown organizations, trans-led organizations that understand the very nuanced world of my community, right? And oftentimes we understand how to center our community and not see them as a demographic to be targeted, right? We really affirm them as a person. We have direct interaction with them, but we also have very radical ways of knowing how to really engage with them. And I think oftentimes when we talk about whether you're talking about PrEP or you're talking about HIV adherence, oftentimes when you look at the Black MSMs, those numbers are not going down, have not gone down for quite some time. So it speaks to the fact that, we have these institutions that we continue to pour millions and millions of dollars into, but yet the community most impacted by these disparities are still not seeing any type of improvement in quality of life, adhering to medical regimen. So one of the things, I do within my organization, we have what is called it's really connected to the church. So talk about church hurt and how a lot of us, we walk around with that church hurt. And so oftentimes, we know all these things are out there for us, but what's in my mind, I'm going to personalize it with me being growing up Kojic in Beaumont, Texas, is what pastor says, nothing good comes from this lifestyle, right? Pastor says the wages of sin is death, right? Pastor says God made Adam and Eve. And so what happens is, if we're not addressing that, we're not addressing why a lot of Black MSMs, even though they know that there's condoms, there's PrEP, there's ways they can protect their bodies, they're walking around with that condemning spirit that oftentimes these white institutions are not aware of, and they're not even creating programs to address that. So I think also, it's really important for us to think about how we are divesting from these institutions that have been have monopolized this work for decades, and yet Black and Brown folks are still at the very bottom, 30 years into an epidemic.
I want to thank you for that. I want to, so we have about 20 minutes left or so, and I had a feeling this was going to fly by, right? But I wanted to get to Rafi's comment. I have one more general question, and then I have kind of some specific questions to ask each of you. And thank you for your responses. This is super, super great. Rafi?
So quickly, I just want to add to what Dr. Britt was saying. It's also where even before people interview, is where we advertise so people can see that something is quote unquote menial, some people would call it, but it's really important what type of community you're letting them know. I'm here and I want you to be part of this, whatever this is. I think that's really important. And I'm thinking right now I'm a harm reductionist. I've been working in harm reduction for 20 years. That sounds silly when it comes out of my mouth. But there's a lot of peer positions, people who are active or past use in the past. That's can also be fair game and in your recovery process, of course. But many times when we think about these positions, the position is that small position, that entry position. So what you're saying is that life experience, it's only to bring you in, and then you're expected to be a professional, which means more of what we just were talking about, whiteness, and you must do this in order to be professional. If it's a woman, you must conform to these more male-guided norms. If you're Black or Latinx, you should conform more to this white approach to work, right? So we should really watch out. And in the harm reduction community, there's this peer position that's the life experience. And we turn that around and say, no, what we want is a peer director as soon as we can. Because peer and being a drug user is the gaze upon which you can do better work, not a position in the organizational structure and such. So our positions are not peer. The peer is your strength, and the position is a full position, just like anybody else, like outreach worker, coordinator. So a peer in theory could be up to director, and that's what you want. Empower people to come up through the ranks and using that life experience, whatever that may be in the case of this HIV world, right? To strengthen the organization, because that's a life experience, and it's very important to lift up.
We are the experts in our own sort of stories and our journeys, right? As a person living with HIV, I know what my condition is and what works for me. This was sort of referenced in the previous session, and I think it's important. I think it's super important, and I really appreciated the framing from Shembria and Obrinka about how we all have bias and how we all have things that we sort of bring that we need to sort of dismantle. And I just wanted to ask the panel, what can we do as individuals to address our own biases and our own internalized racism? And some of our internalized homophobia, some of the church piece that Chiara was talking about. How can we ensure that we're not bringing that into the communities that we're trying to engage with and be responsive to?
That's a huge question.
Yeah, that's a good question. I definitely, I say we all just need to be more cognitive, and I know I got into, I'm a woman of trans experience. So oftentimes, but I'm also of a certain age, right? So, I adhere to a binary. And so even me, I have to learn, there's new ways people are identifying, right? There's new, everyone who identifies as a woman of trans experience, they're not necessarily, doing the surgeries or getting on hormones. And I remember having a conversation with my girlfriends. I'm like, well, we went through a ritual, right? Where we didn't just start popping moans and start going to the women's bathroom, right? We actually took hormones, kept on going to the men's bathroom until we were a disruption in the men's bathroom, right? And then we're like, oh, it's time for us to start using the women's bathroom, as opposed to a lot of, younger trans women, I'm not trying to be dismissive, but they just started taking a hormone yesterday, and it's like, oh, I'm going to the women's bathroom. They're gonna have to, and so even I had to learn, people, it's a different generation. People are I can't tell someone when their journey of womanhood begins, right? Because my journey was different for me. And so I just wanted to speak to the fact that even as a person of trans experience, those implicit bias pops up, right? Where we're like, well, why don't you wait another year before you go into the women's bathroom, right? And see the hormones work on your body. But working with people who have told me no, that doesn't go today. Maybe 20 years ago, but today we have rights and protections. And so when we talk about implicit bias, it's really about just doing the work, right? Doing the work, trying to get better at understanding that everyone's experience is not going to be your experience, even if they are of the same community that you are of, And so I think it really starts there. It's really just being open to understanding and respecting the choices that people are making in our community.
Fantastic. Thank you for sharing your personal experience. Rafi, Britt, do you have thoughts?
You want to go ahead, Britt?
Sure. I mean, so I think about this, right, as part of it being the work of empathy, and that begins with us, right? But it also begins with us decentering ourselves and thinking about how do we center folks who are relegated to the margins within the margins. So, I feel like folks always say, check your privilege. And I think that's cute, right? We should absolutely do that, but that's not really as useful to me as you doing something with your privilege. And so if you know that BIPOC folks are being discriminated against when they're trying to get housing, go to the open house on their behalf, drop their application off, be their advocate, right? Do the negotiations when someone is trying to have their home appraised, because we know appraisers tend to value homes that are owned by BIPOC folks as less than they're actually worth. And that's stealing millions and billions of dollars from communities that could use that sort of wealth and that generational wealth, right? And so for me, I always think about this in terms of, I don't need people to say I have privilege. I need you to show me what you're going to do with that. For me, that looks like as someone who is cisgender, as someone who presents as heterosexual, even though that's heteroflexible, right? How am I making space for trans women in everything I do? I created a digital counter community called Cita Sister, and we intentionally created shirts that is sister with the S, not CIS. We are talking about women, trans women are women, right? And we made that a core value of what it was we were doing as graduate students, or even now, I'm a light-skinned woman. I know that people respond to me differently, at least before I open my mouth, because I'm light-skinned. So I'm a little bit less jarring to white folks. For some reason, they think I'm safe. They're wrong. I'm the most dangerous person in the room at most times, right? And so how am I then elevating what darker skinned women are going through? It means I added colorism as part of my research agenda. I am talking about the fact that, yes, we are all Black women, but I know my dark-skinned peers and colleagues experience whiteness differently than me because I am on a color spectrum closer to whiteness. And so that gives me some opportunities and privileges. And so I think for me, a piece of it is not only in acknowledging what it is that we experience, how we navigate that, but what are we going to do about it? And if you don't feel safe to do something about it, spend your money. Spend your money. If you have money, the fastest way that you can do something is to do direct cash to people who know exactly what to do with it when they're struggling with or suffering under the isms and the weight of oppression in our society, especially right now. Give it up.
Fantastic. Fantastic.
I don't know if I could add much to that because that was like spot on, right? Of course. But I would say, for example, if there's a new organization coming online, how to watch out for this. I think that they have to do that active listening at not only at the admin level, but at the organizational level, and be open to learning, right? When you stop doing that and listening, then you're going to fall back. And supposedly we're in this growth continuum that we got to keep growing, right? It's not going to be linear, but there's growth. So the other thing is stay open and be sensitive. That sensibility, I think it's key, because what we're basically doing is consciousness racing. That's part of this work. It should be consciousness racing on very different levels. We should be thinking of race and Du Bois. We should be thinking of class, and that is the level of engagement we should be having. And then, of course, this is all well and good, but if you don't take action and give those positions to people who actually need it, like for us in harm reduction, is to that active drug user who is in an area that they not only that they really need it, but that this is part of the key to their life to be in a better space, right? So it's about that investment, right? Not only just think about it, put the organization in the right spot, but also take action, which comes with risks in many ways. I mean, some funders would like that. Some funders will not like what I just said, right? So there's some risk taking in terms of this work also.
Fantastic, thank you. So in the time we have left, I actually, I wanna go ahead and ask just one more sort of big question, because I think y'all are dropping all kinds of knowledge, and the chat you're getting all sorts of accolades in the chat. I think it's a two-parter. In your own assessments, professional and personal, of racial equity in your community, what ways have you seen it influence health and social outcomes? And then the second part is, what initiatives or partnerships have you meaningfully seen address racial inequities as a response that can be promoted to others, that can be modeled, that can be replicated? And the fact that there may not be an easy answer to that shows us perhaps how much work we need to do.
Let's talk about that question again. So can you do the first part again so we can start teasing it out, because there's a lot.
Teasing it out. Okay, so in your own assessments, professional and personal, of racial equity in your community, what ways have you seen it influence health and social outcomes? This is when it's being meaningfully put into place and put into practice. So what initiatives or partnerships or ways have you seen community or different sort of settings address racial inequities that are a good response, that can be promoted to others, that made you come away feeling like, okay, they're doing this, they know what they're on the right track here?
I don't know if I feel like I have a lot of good examples, and I don't like that that's my answer, right? And I say that because for me, meaningful change means that we are making some progress, right? Slow progress is progress. And I feel like we are very much in a time of regression, of repression, of the stripping away and the decentering of folks who need these resources and community support structures most. And so I don't know that I have a lot of examples, especially in higher ed, right? One of my biggest frustrations for me being an academic is every institution has started doing land acknowledgements. That's cute. How much land are you giving back to Native folks? Or institutions are out here talking about, we acknowledge the role we played in enslavement, Great. How many Black students are going to school for free? And so for me, I feel like there's a whole lot of lip service, but not a lot of actual action that's taking place. And so I kind of struggle to answer this question. But when I do think about organizations that I look up to, it's, I'm an Atlanta native. So it's Sister Song, it's Sister Love, it's Black Women's Health Imperative. It's folks who happen to be in organizations that are usually women of color led, right? Let's just call a thing, who are doing the real work and talking about how do we engage meaningfully, and then how do we do harm reduction, right? Because we know even in amongst women of color, there are ways that we harm each other. Anti-Blackness is global and pervasive. It happens in every community of color, right? And so how do we facilitate space and opportunity for us to mitigate and work through some of that? I think there are organizations that are doing it. I think we don't really get to say this is a wonderful example because we don't know that they're doing it, because they're not getting the funding that places like Planned Parenthood and some of these other organizations that I love, right? And I have a lot of critiques of them. And so, I think a big piece of it is the organizations we tend to know the most about is because they have a PR arm. They have folks telling us and communicating to us, these are the things that we've done that are so wonderful. That's cute. But where is the work actually being done? And so I think for me as a researcher, that's where I am in my research journey, is looking to see who is really doing some of this meaningful work. I'm about to start a study with Black college women, asking them, how are you learning about your HIV risk, specifically for Black college women in Metro Atlanta? Because Georgia is #1 in new HIV infections. Heterosexual Black women are the fastest growing demographic of HIV infections in Metro Atlanta, right? And so we frame this as a crisis that impacts Black and Latino gay men, and we've done some really great advocacy work around that, and that number is still true. But when we talk about shifting demographics, there's an entire population that we're missing. Heterosexual, cisgender women, transgender women are having sex with the same men in Atlanta, which means the HIV crisis is one that cuts across all of our experiences, right? So who are the organizations and people on the ground that are doing that work? I don't know the answer to that yet, but give me 2 years and I'll be able to tell you when I'm done with my study.
I have no doubt that you will. We look forward to it. Other thoughts from Rafi or Kiara?
If I may jump in, For me, the best part of this was to go in. Okay, so in Puerto Rico, we have a section which is called Loíza, and this is where traditional Black Caribbeans were held in the outskirts of the city of San Juan, right? This was outside, and it's a traditionally Black community, and that's where I was referring to earlier. Of this is the community that has been left, so they're not approachable. I think that was the best way that we saw it. And when you repeated the question, I remember how participants saw when some participants were looking at us, it's like, okay, so here comes this group from outside of our community saying they want to serve us. Let's put him let's put him in the hot seat and see how they work. They put us to the test. And we were pretty deep into the community. And when we talk about pretty deep into the community, it's not just talking to people. It's being at a real risk of something happening and not being in the right place at the right time with the right friends is what I'm talking about, right? So that's what they put us into the test. And after time and connections, they understood that we were there for the long haul. And that was the best intervention that we did I think, I don't know if ever, but that's one of the deepest conversations we had of service provision with the community, because they truly understood that we were taking a risk to accompany them, not to save them, not to help them, but to be in solidarity with them. And when they understood that, when we were there, they understood what we were doing. That was the best collaboration, first with community. So kind of that was the best conversation that we had in terms of we're there for the long run. And then how did we manage that to provide services that we didn't have? our collaboration was with FQHCs that are, or an FQHC that's really close by that people didn't want to go to. So we were the go-between. We're like, okay, so if you don't trust them, at least trust us that now we have your trust or at least your respect. And if let me take you over there and I'll accompany you. So if there's something happening that they won't provide you with the service, we will be there advocating for you. And that kind of really worked. And now we've kind of we are reaching that outreach is paying up. People are accessing services that before they felt that they couldn't access. So that's as close as I can get to response to that deep dealing with racial inequality and being part of a type of solution.
Well, I think that speaks to what Dr. Britt was talking about earlier, like how you advocate for community and showing, connection and using your privilege to really help people access care. In Kiara, we've got about 4 minutes left, so I guess I'll give you the final thought.
Yeah, thank you. I just was thinking also, here in New York City, Black and Brown trans women have been in the forefront, Department of Health, all these other places talking about investing in the trans community, especially BIPOC community. And so what I think about is like one of the meaningful things we have here in New York is the Department of Health, their public health services, they funded for Black and Brown trans-led organizations for capacity building, right, for 4 years. My organization was one of them, and so it speaks to that type of investment of like, understand, you hear from the community, you hear the community say that this is what our needs are. You're hearing us say like, you need to invest in our community, in our organizations. And so the city is hearing that. So that is one example. New York Women's Foundation has been doing an amazing job as well. Another one of our funders. So like that type of meaningful involvement is really funders and folks who are in those positions of privilege, right? As you were saying, Dr. Britt, using that place of privilege and saying, you know what, why not pour money into these organizations that do not traditionally get the funding that these other organizations have gotten. And so that's one of the main examples I have of meaningful engagement when it comes to people leveraging their privilege and their power and pouring into emerging communities. I don't want to take up too much time. So.
No, that was fantastic. And as a part of the AIDS United programs team that does grant making, that is a mission and an objective of ours to take funding to really get it to resources and communities that truly, truly have need and to lower the barriers as much as possible. That was a plug for the HL Pop initiative again. So I just wanted to take a moment to say thank you again as we are coming to time with this session. I feel like we could have kept going for another couple of hours because you all just have such a wealth of information and perspective. It's always a joy to work with each of you, and I wanted to thank you again for your time and to thank the team for inviting us to all be a part of this. And I guess right now I'll hand it back over to Obrinka and Shambria. Thank you.
Thank you so much, Julio. Thank you so much to our panelists. Amazing. I was over here as a Southern girl born and raised in the Baptist church. I was about to throw a shoe at my computer screen because y'all were giving me everything. And I thank you so much. I needed this. I know I'm not the only one that needed this. Conversation like these not only remind us of the things that we have to continue to work for, but it just refuels us. Like we talked about in the beginning, you have to know when to kind of take a step back and fill your cup up. This most definitely filled my cup. And so I really appreciate you all for this amazing panel, for the amazing discussions that we were having in the chat, and just your interaction and your undivided attention over these last 2 hours. I'll pass it to Shambria to close us out.
Yes, like Brink, I share sentiments. Thank you all so much, Julio, for your facilitation. To all the panelists, you all did great and amazing. And to everybody that joined this webinar, thank you for being a part of the conversation. Thank you all for your thoughts and your opinions, because it all matters and appreciated. So until next time, from AIDS United, as well as everybody on here, thank you, and you all have a great day.
Bye.